So this is Wara. She's an 11-month-old girl that was in September 19th of last year, about this time last year. She was the youngest patient to be discharged from the Ebola Management Center, or sometimes we call it the EMC, which was managed by Médecins Sans Frontières, MSF. And of all the horrific things that we saw in last year's outbreak, this was one of the happiest days that we had. This 11-month-old girl had survived the ravages of Ebola virus disease and survived to discharge. But there wasn't that moment of celebration. There was a time when all of us went through this, and we almost simultaneously went through it, where they started to realize just what would happen to this girl now. She was 11 months old. She'd lost both of her parents to Ebola virus disease, and her community had been ravaged by Ebola virus, and there was very few surviving members left. And just to see her get through, and then to realize some of these things, that she would probably have some of the sequelae. Both her parents, as I said, were died, and she would probably have a lot of the sequelae of the Ebola virus disease. So we started to realize that there's some good parts to this outbreak, and there's some really bad. And as a pediatrician and as a guy that studies viruses, especially the high containment viruses, I get a chance to actually go to these outbreaks once in a while. And the case of Wara is particularly poignant for me because I've seen some successes both in the hospital and in the lab, but also those failures. And we celebrate those successes, but I think we learn more from those failures. And every couple of years, we get to go to these outbreaks and help the Médecins Sans Frontières doctors and the WHO people to perform the diagnostics on testing on the patients that come into the ward. And so what we do is we run the PCRs to tell which of the patients have the Ebola virus disease and which do not. And in the case like Wara, we get to see a few of them that actually get discharged, and you can test them to see that they no longer have the virus. And we get to celebrate those facts. So what I'm going to talk about tonight is really kind of some of the highs and the lows that we have with some of these outbreaks. And more particularly, focus on some of the misconceptions, some of the truths, and how some of these become myths, but then they're based on some semblance of truth. So that's that cognitive dissonance. This is the first one. It's incredibly contagious, very transmissible, or easy to catch. Now, so this is some of the hyperbolic statements that have been said by one of the Republican presidential candidates. Anybody guess who it might be? Just shout it out. Yeah, no, it's not Trump. I hope you'd say that, though. But actually, it wasn't Trump. It's by Kentucky Senator Rand Paul. And Rand Paul is actually a doctor, so he should really know better than some of the things that he was talking about. But in some ways, he's really quite correct. It is quite highly contagious and easily transmissible. But it really depends on the context. And this is a picture I took last year when driving through the community. This is very close to the community that had the index case of the first Ebola virus in December 2013. And in these communities, basic health care is really non-existent. So if one of your family members comes down with a disease, you're going to have to look after them. And if they have vomiting, diarrhea, their sweat, their tears, even their urine, anything that you would have to clean up is extremely high in virus in the later parts of the disease. And if they end up dying, all the preparation for the funeral has to be done by the family members. And in particular, the women do most of the preparation for funeral. And that includes expunging the body fluids, washing the body. And then when the community members come to the funeral, they will kiss and hug and send the body to the afterlife. So you can't think of a much better way to spread Ebola virus disease. And we know that Ebola virus is really, really high levels of infection that comes from the bodies. So this is what happens in equatorial Africa, where they're very poor conditions. Surely that couldn't happen here. Well, this is a rather famous case. This is Thomas Eric Duncan, who, again, about this time last year, presented to the Texas Presbyterian Hospital with symptoms that were, fairly nonspecific. A little bit of a headache, abdominal pain, and maybe a mild fever. He wasn't originally recognized as having Ebola virus disease at the time because they didn't know that they didn't recognize that he had come from Liberia. And so he was sent home with a diagnosis of sinusitis. He was given some antibiotics. And he was looked after there by his family member for the remaining 4 days. And of all those family members that were looking after him, none of them came down with Ebola virus. So maybe it's not so highly infectious. And then he got worse. And then on September 28th, he was readmitted to that Texas Presbyterian Hospital. And so big sigh of relief. He's one of the big major centers. He's in a tertiary care hospital. He's being looked after by people that know what they're doing. So you think, okay, we're safe. Everything's good. No, paradigm shift again. Unfortunately, 2 nurses were infected in providing his care. So this brings me to the next myth. Ebola is airborne. And this is one of the biggest contentious points about this last outbreak. There was lots of sensation about the fact that Ebola had gone airborne. Maybe this virus was different than all previous ones, or maybe that we just hadn't recognized it until now. Well, the truth is that Ebola is not airborne, not in most circumstances. And if you go to the Center for Disease Control's website, or the World Health Organization, WHO's website, or even our own Public Health Agency of Canada website, you'll find very strongly worded statements that'll say that it's not airborne. You're not going to catch it from riding on a plane or riding on a bus with somebody. But if that's the case, why do the MSF workers wear this? They're covered from head to toe, and there's not an inch of exposed skin anywhere on the body. And if you look at their masks, they're wearing a surgical mask on the outside, but underneath it is an N95 particulate respirator. So why are they wearing a particulate respirator if it's not airborne? And even more representative, why are quarantine officers that have to go onto a plane, and this is United Flight 845 from Punta Cana, or from Philadelphia to Punta Cana, after a guy said an Ebola joke. So it doesn't exactly inspire the confidence in those websites saying it's not airborne. Well, the truth is, as I mentioned, it's not airborne. It's not really airborne, and this is how we manage the cases. You can see that this doctor is reading some of the medical information on one side of the double layer of snow fences, which is separated by only 6 feet or 2 meters. And the guy on the outside is really basically just wearing street clothes. And that could very much be a patient talking to a doctor on the other side. So it is definitely not airborne. It only can travel about as far as I'm spitting on the people in the front row. There's no people in the front row. So we're pretty happy that it's not airborne. And another case in point of this is Dr. Craig Spencer, who returned from Guinea last year. This is about October 24th last year from Guinea. And he returned to New York City. And he had some mild symptoms. He had a little bit of a headache, and just really wasn't, and abdominal pain. Wasn't feeling very well. So what did he do? He ended up going on it wasn't terrible. He didn't recognize the Ebola virus. And then he went on the subway. He actually went to ate a meatball sandwich at a local restaurant, and he even went bowling. And the public health people that were surveilling all the potential contacts, which were thousands in New York City, had to track down all these people. And they had a big collective sigh of relief at the end of that 21 days. So my first myth about the fact that it's highly contagious, it's probably not in the early stages. So what's the difference between Craig Spencer and some of these, Thomas Duncan, who was looked after by his family, and then later on Thomas Duncan was looked after by nurses wearing personal protective equipment, and they still came down with it. What's different? Well, early in the disease, when you can go on the subway and go for a jog and go eat a meatball sandwich, you're probably not going to spread the virus very much because you're not shedding that much virus. But later on, like Thomas Duncan, when he went to the hospital, no longer could get out of bed, had to be intubated and ventilated. So intubation and ventilation, we know, is an aerosol generating procedure just by nature. If he vomits and splashes on the floor, that's an aerosol generating procedure. So it really depends on the circumstances. I like this slide because it talks about the secret serum that was, Sanjay Gupta was talking about this in the summer last year. And there is no secret serum. There was something called ZMAB, which was created, which was a collection of monoclonal antibodies, actually 3, 2 of which were designed in our lab by a brilliant scientist that works with our group, Zhenzhou Chu. I'm butchering her name. We call her Chu. And she developed this out of the monoclonal antibodies, and it works very well in animal studies, but it had never been tried in humans. But because this Ebola outbreak finally hit a few people the few Americans that actually had come down with it, they had to try something, and they asked if they could have these antibodies. And they actually seemed to work. They seemed to work with supportive care. So it's not a secret serum, it's just there was very limited samples. There was only 9 full treatments at the time when these cases happened. Which brings me to my next point, is that Ebola virus equals an automatic death sentence. Almost everybody thinks that. And for the most part, that's kind of true. One of the big things is that in previous outbreaks, 90% of the victims died. In this outbreak, 70% of the victims died without treatment. And these are without treatment, which means that you basically go someplace, that's where you're going to die if you get no treatment. But of all the cases that happened in North America and Europe, there were 24 cases, there were only 5 deaths. So that's much better. And the ones that died probably presented late or were rescued late. And including the ones that were treated in hospitals in Africa that were provided really good levels of care. In some of those places that gave just basic IV fluids and oral drugs and IV drugs, in some of those places the mortality was in the 20% range. So how does this work? And this is the deepest science part of my talk. And it's really what it is a race between your organ system's health failing and your adaptive immunity kick in. So your adaptive immunity is your blue line. And your organ systems start off at about 100%, but then due to the ravages of Ebola virus, they start to fail one by one until they reach a critical juncture and you die. So one of the things that we can do is if your adaptive immune system can be augmented, there we go. If you can augment the adaptive immune system through vaccine or the ZMAB, that collection of monoclonal antibodies, or convalescent sera, which is the sera from a patient that has had the Ebola virus and then survived, you can shift that curve to the left, and then therefore your organ systems don't fail as much, and maybe you're going to live. The flip side is also true, that maybe what we can do is we can support the organ system by giving IV fluids, IV fluids, supportive care, or renal replacement therapy. We know that the kidneys are a particular watershed area. So if you can replace them, and maybe we can shift that curve to the right, and again, circumvent death by having your adaptive immune system kick in before your organ systems fail. So I think, just for a second, I want to go back to war and just say that I think we can celebrate the success that came from war. And say that, like Wara, she had survived the ravages of Ebola virus disease. She had, but we had that cognitive dissonance that she was going to go through this really, really awful, that is going to happen now. She finally got through the disease, but now she's got no family. She's going to have some of the sequelae of the Ebola virus. She's going to have vision problems, hearing loss, potentially cognitive neurodevelopmental problems. She still couldn't walk or eat on her own. So I think we can celebrate. This is think we can celebrate some of these science, the science that came from this last Ebola outbreak. And this is Cecilia Camara, who, when she heard that the VSV vaccine that was developed again in our lab worked, she put up this sign, and one of the photographers took a picture of her, and she was very happy, clearly, about it. And I think we can celebrate that, but I don't think we can just pat ourselves on the back and say, yeah, we did a good job. We cleared the Ebola virus from war, we cleared the Ebola virus from these 3 countries, and we could just walk away. And I think it's just kind of exemplified by this slide, by Save the Children. They estimated that $4.3 billion was spent on the Ebola virus outbreak by external partners in the fight of this Ebola. And they also said that if you had spent $1.6 billion in 2012, that would have brought that healthcare gap up to a basic level that maybe 28,000 people wouldn't have had Ebola virus disease, and maybe 11,000 people wouldn't be dead. It would have been recognized much earlier. So to finish off, I just want to say there's going to be a long road to recovery. So like WARA, these countries are going to have, a lot of the work is going to continue from now on. And I took my title from a Kurt Vonnegut Jr. book that said that, sometimes the most beautiful peonies grow in the biggest pile of cat excrement. And I think it celebrates kind of this cognitive dissonance that was going on with this Ebola virus outbreak. This Ebola virus outbreak in particular was a big pile of cat poop. And piled onto a bunch of countries, or 3 countries in particular, that have really been dealt a very poor hand. And I think if I can make one call to action, it's that we should all still continue to support countries like this, however you can. Volunteer for an NGO, volunteer for something that will provide some help, or even provide some money for a charity of your choice. And I think maybe if there's one good thing that can come from this big pile of cat excrement, that was this Ebola virus outbreak, maybe it is something beautiful that can come out of it. So thank you.